Welcome to our first webinar in 2016. Today's webinar, we are going to talk about understanding the Haring-Pulse test, and the presenter will be Dr. Renato, who is MD Assistant Professor. Sorry, I forgot to change the slide. Dr. Renato is an assistant professor in Pará, in a university in Brazil. My name is Mariana. I'm the moderator of this webinar today, and I'm educational and training manager at Otometrics. A little bit of the practical about this webinar today. All of you are muted, so we are not going to hear, so we reduce the background noise, so we can't hear your questions, and that's why we have a question box. So I will ask you if you have any question to use the question box in your right side of your slide. The questions will be collected during the session, and at the end of the session we will answer your question. If we don't manage to answer all the questions, we will reply to you by email after the webinar. If there is any technical problems, please write to me directly, and I will try to resolve from here the problems that you are having. So now, please, Dr. Renato, it's your turn to make us a little bit clever.
Okay. Are you seeing my screen here?
Yes. Yes.
Okay. I'd like to thank you, the Otometrics, for the opportunity to be here. And I would say good morning because I'm in Brazil, and right now it's 9 a.m. I know there are some people in, Europe and Asia, and, so I would say good afternoon or good evening to everybody. So what we're going to talk about today is about the video Haring-Pulse test. Of course, there's a huge topic, and we don't have time to go through all the details here, all the artifacts and the clinical applications. So what I decided to present today is an overview. It's some background about physiology, and to show us some clinical applications in how the vHIT can help us in our daily basic practice. And I'm such a guy that likes history. I think that when we start studying history, we can understand where we came from and where we're going. So I'd like to take 2 minutes of your time here to tell a little story here about one guy. This guy is Robert Barney. I guess everybody knows him. He was born in Vienna, and he was graduate in the University of Vienna in 1900. And Dr. Barney, when he was in the medical school, he was pretty much convinced that he would become a psychiatrist, especially because he had a great professor, well-known Sigmund Freud. I guess everybody knows him. And, in the last year of the medical school, Dr. Barney, he decides to become an ear surgeon. And he was under influence of Dr. Politzer. And, like us, Dr. Barney become, ear surgery. And in 1906, he described what we call caloric water irrigation. And, it's funny because this clever observation comes in a very untypical way. He was like washing out some chronic ears, and he just realized that when he used warm water, you got, vertigo and nystagmus beating to one side. And when he used cold water, the patient still having vertigo, but the nystagmus beating to the other side. And he comes, to description of, calorics, and it was a very controversial. He got some trouble with some of his colleagues for intellectual properties. But the point is, he described that, and he becomes a world famous for that. As every enthusiast of the medicine, Dr. Barney becomes a volunteer for the First World War. And in the first months of the war, he was kept as prisoner in Russia. And, the interesting part of this story is that in 1915, when he was a prisoner, Dr. Barney, he was laureate with the Nobel Prize. And that had been a negotiation between the Russian Tsar and the Prince of Sweden to release him and he could, get his Nobel Prize, and he could join this very, selective team here of the Nobel Prize winners. So why I'm telling you this story here? Because since 1906 until now, we still using calorics. I mean, calorics is the widely most used test for vestibular functioning. I mean, it doesn't matter if you are in South America, in Europe, in Africa, in Asia, or in the United States, calorics is the most popular way. And at least in my opinion, there's no other test that we have been using for more than 100 years, and they're still popular. So my point is, I guess in a few years, video head impulse test is gonna, take one out of this caloric importance for many, many reasons. We go through these reasons through the presentations here, but I have no questions that vHIT is gonna become, very widely used. So when we talk about, there are three big problems. In any vestibular test, you have these problems here. First of all, there is no test that could evaluate all the sensory organs from the inner ear, which means you can use vHIT for semicircular canals, you can use VAMP for the maculas of the utricle and the sacral, but there's no one test that could test the 5 sensory organs, and that's a problem. The second problem is that all of the tests, they are functional, which means you're not testing the, the inner ear itself. You are testing, muscle responses that comes from the labyrinth, which is an indirect way to test the labyrinth. There's not direct test at all. And, the third and maybe the most important one is that vestibular tests, they give us no diagnosis, which means, if you're, expecting to send a patient to a vestibular lab and, expecting to find out if the patient has Meniere's or PPPV or neuritis, you're not going to, find it out because they are just functional tests. I mean, the vestibular test can tell us if your labyrinth is, it's working properly or it's not. But I have a friend of mine, Professor Rauch from Boston, and he used to say that to send a patient to a vestibular lab and say, look, this patient is dizzy, please do a vestibular test. It's the same thing to send a patient to a radiology department and say, look, the patient is sick, please scan. So what's the chance of the radiology to find out the disease? I mean, none. So this is 3 big problems about all the vestibular tests here. And when I start talking about the head impulse test, has been described first for 2 professors in Sydney, Australia, Dr. Halmagyi and Dr. Curthoys. Dr. Halmagyi is a neurologist. Dr. Curthoys is a scientist. He's a PhD. And they described that in 1988 as a bedside test. There's a nice picture from one of my colleagues in Brazil with Dr. Curthoys. This picture has been taken last year in, in Otometrics master class in Madrid. And, the basis of the head impulse is the vestibular ocular reflex. We know that the vestibular ocular reflex is the ability to keep our eyes in target while we move our heads. And it's a very fast pathway. It involves like 1, 2, 3, or 1, 2, 3, 4 neurons. Very fast reflex. It happens about 8 milliseconds, which is quite fast. And here's a video with Dr. Halmagyi performing the head impulse test in one of my colleagues from Brazil, Dr. Zuma. And, head impulse test, it's a very simple bedside test where the patient is asked to look to a stationary target while the head is turned. And you can see that it's a turn in a very high velocity, small amplitude, and high accelerations. So what we do expect in normal subjects is the ability to keep their eyes steady, at target while we're moving their heads. But, if you have a, deficient VOR, the patient cannot be able to keep their gaze stationary, and you can see, some catch-up saccades to do the corrective movements. So here's a nice model, nice, beautiful young lady from Dr. Tillman. and you can see that she has the ability to keep her eyes in target while we move her heads. So she probably has normal vestibular function here. So there's another patient here, and when we turn our head to the right, oops, something happened here. You can see, look in slow motion here, you can move to the right side, and the eyes do a corrective saccade to the left. And I can conclude that the right side is damaged. So it's another patient, and we are moving his head to the left, and he has a corrective saccade. So I can tell you that the left side is not working properly. That's very nice, nice test, but you know, head impulse has some limitations. I mean, the clinical one. What is the main limitation? First of all, it is a subjective test, which means it depends on the ability of the examiner to identify the corrective saccades. Sometimes it's not easy. Sometimes, you know, if you're not so familiar with the test, or if the patient has some, you know, cover saccades, it's not so easy to see the over saccade. So it's a subjective test. Second one, it's a very hard to test the vertical canals. I mean, you can do that, but it's not so easy to test the vertical canals. And it is a quantitative test, which means I can tell that the labyrinth is not working properly because the VOR is deficient, but I have no way to measure that. So I know it's not working, but I have no way to tell how much it's not working. And it's hard to document and file, which, you know, you can use your iPhone and, you know, record the eye movements, but it's not easy. So for those reasons, you know, the Sydney group started the research to develop what we have commercial available right now, the ICS Impulse. And when we see the ICS Impulse, it's not a 1 or 2 years research. There's a lifetime research. You know, there's a picture from Dr. Halmagyi, and here you can see all the different prototype video head impulse tests. You know, first prototypes, they try to use 2 cameras and it becomes heavy. So there's many, many, many years of research to achieve what we have commercial available right now. And this is a nice paper that comes out, you know, last year from Dr. Newman Tucker from Baltimore and, you know, Sydney Group. It has been published, I guess, probably in November of 2015. And in this paper here, I put this picture because I think that's quite interesting. This is a timeline. This is a timeline since 1988 when Dr. Halmagyi and Curthoys described the head impulse until now. And you can see in this timeline all the different, you know, discoveries and research that have been done to video head impulse tests, which you can see that there's a, you know, there's a hard job, you know, there's a lifetime job here. Well, to understand the vHIT, you need to understand a little bit about physiology. We know that, you know, the head impulse is based on the idea there is a asymmetry in the excitatory and inhibitory response. So we know that our vestibular has a neural firing activity even at rest, which is about 100 spikes per second. And when we, you know, move our head to one side and the stereoischemon bends over the kinesiologist, we have an excitation, and this excitation is proportional to the head velocity. If you move your head fast, there's a huge excitation here. It comes from 100 spikes to 400. And in the other side, you do have an inhibition. But this inhibition here, it comes from 100 spikes per second to 0. It cannot go below 0. So this asymmetry is detected and is the base of what we call 70 volts law. And, you know, when we start talking about vHIT, I have a lot of, you know, students and residents, and they ask me about what is the VOR gain. The VOR gain is nothing more than relation between the head velocity and the eye velocity. We know that when we move our head to one side or to the other side, our eyes supposed to be on target, which means they do exactly the same movement in the same amplitude, in the same velocity, but in the opposite direction. So the concept of the gain is the relation between eye and head velocity. And in normal subjects, it's supposed to be 1. So what the vHIT does, you do, you know, head movement here, you have the head movement and you have the eye movements. And for make the display easy, the software inverts the eye movement, put together, and you do that a lot of times. And that's, that's the image you have in the video head impulse test. Continue with the physiology here. When we move our head to one side, fast, but not as fast as an impulse, you do have, an increasing in neural firing activity in the right side. So it comes from 100 to 200. And you have an inhibition in the left labyrinth that comes to 100 to 0. So the information that comes to the viewer, they are proportional. And you have your head and your eyes falling through very precisely. When you do an impulse here, you do have a very big excitation in the right labyrinth here. It's proportional to the head velocity. So you come from 100 spikes per second to 300 spikes per second. And in the left side, you do have an inhibition, but the inhibition, go until 0. You cannot go below 0. So the information that comes to the viewer is not proportional. So that's why sometimes you do have a small difference between the head velocity and the eye velocity, even in normal subjects. When we think about a pathological situation here, here's a patient who had, vestibular differentiation in the right side, which means the right side is not working. And when we move our head to the right, there is no excitation in the right, but that is still having an inhibition in the left. And that's why you have a low gain. The eye cannot follow the head, but you still having some response. And the response here, it comes from the left side, which is, in this example here, it's normal. But the right side is damaged. So that's why you don't have no response at all. So when we took the same patients and move our head to the left side, which is the healthy side, you do have an inhibition, you do have an excitation here in the left side, but you do not have the inhibition in the right side. And that's why you have, not match eye and head velocity. And this is the explanation for sometimes when you have a patient that, had a vestibular nerve section in one side and you do the impulse to the healthy side, the gain is not so normal. It's because the absence of the inhibitory component here. So we have to be familiar with the saccades. What is the saccades? Saccades are, corrective movements. It's what we do to try to keep our gaze in focus. When we move our head and viewer is not precise, is deficient, we trigger a saccades, which is, catch up the eye to put in the primary position. So here's an example. You have the head velocity and you have the eye velocity. So it doesn't match at all. So it triggers a saccades, which is a very fast movement that comes, it takes much more than the 8 milliseconds of the VOR. We know that saccades, takes for around, milliseconds to be triggered, especially because the cortical involvement. So, and this is the reason. The VOR is quite fast, and the saccades has a different, pathway. So, in this example here, you are moving the head of this patient to left side, and you see, oops, a saccade here. So, this is over saccades. This is a saccade that our eyes can see. But, the Sydney group, Dr. Weber and Dr. McGarvey, Curthoys, Halmagyi, they have published, in 2008, what he called covert saccades. Covert saccades are some of catch-up saccades that are triggered while you move your head. You have the over saccades, that is saccade that happens after the head stops, but you still having some of saccades here that is triggered while you're moving your head. I know that first time we look at that sounds confusing, but it's not. And this is a video, Mariana gave it to me, and this is a very interesting video. Here you can see a patient, when we move to the right, you see a corrective saccade here. So they have a right side problem here. The left side seems quite normal. This is over saccades. But when we do, is here, look, you move to the right, seems normal. You look to the left, and it still seems normal. But if we look this patient in a very slow motion, like frame by frame, you're going to understand what is covers a case. Look here. The patient's moving the head, moving the head, moving the head to the right, the head's still moving, and oops, and the head's still moving. So this is covers a case. And this is a case here you didn't see with the naked eye. But the video head impulse can show us that. So is that clear, the difference between the cover and oversight case? I hope so. If you're not, we're going to go through, the questions. So first of all, we need to get familiar with the hardware. I mean, this is the commercial available head impulse test, the ICS impulse. It's, it's a very light goggle here, and this goggle is connected to your laptop or your computer with a USB cable. You have a right side camera, and you have, infrared camera with a gyroscope and accelerometer and a crystal to reflect the pupil. And, the great advantage of the ICS impulse is because they have been, trying to comparison with the surgical coil, which is the gold standard for studying eye movements. So they, did this comparison to make sure if the head is, accurate, and it has been published in a lot of different publications here. You see there's a lot of different groups, Sydney group, and, these are some of my colleagues from Baltimore. They have publishing and testing the video head impulse, versus the, surgical coil here. There has been a lot of publications, and we are pretty much confident that the video head impulse give us a very accurate, information. So one of the, things that we should be careful with the video head impulse is with the eyes. I mean, sometimes, you should taking some of your time to make sure that you have a good image of the pupil. For example, this one is not a good pupil. The pupil is like, it's not perfect here. So this one is a very good pupil here. Sorry. This one's a very good one. You see no interference at all. And sometimes the patient has, little dots in the eye, which maybe can give us some problems during the impulse. And another sometimes it's trouble is Asian people, and they have, the eyelids drop, and, sometimes you don't get a very nice pupil. But it's a very easy way to, deal with that. You can tape here in the eyelid and make sure that the pupil is pretty, nice. And, some people have this kind of tattoo in the eye. It's terrible because, in this example here, you cannot do the test because, the equipment cannot detect the pupil at all. So this patient, he cannot do the test. Another great point about the vHIT is because you can test not just the lateral canal, but you can also test the anterior and the posterior canal, which is the LARC, the left anterior and right posterior, and the route plane. So it's a test that gives us information about the VOR gain in all different 6 semicircular canals. And another, things that we should do very precise is about the velocity. When we just started doing the video head impulse test, one of the most common, errors is because people do the test in a very slow velocity. And we have to remember that when we move our head in a slow velocity, you're not testing the VOR. You are testing the ocular motor system. So the recommendation is that you should perform your head impulse, faster than 120, degrees per second in lateral canals. So this is the ideal range for the velocity. Some of the research, they advocate that you should perform your velocity or impulse as fast as you could. But I just remember that sometimes you're dealing with, old people with some neck problems, and I just don't feel safe to go, faster than 250 degrees per second, but you can do that. And for the vertical canals, the velocity could be a little slower, but not so slow. So I do recommend the ideal range is over 100 degrees per second. So this is one of the questions that when we present anything about the vHIT, a lot of people come to us and say, look, doc, I already have a caloric test in my vestibular lab. Do I need a vHIT? And I use it to say, yes, you do. You do. I mean, the vHIT, when we do the comparison with the calorics, I mean, each of them can evaluate the labyrinth individually, and that's great. I mean, I can test the right side independent, I can test the left side independent. And this is the same thing of the calorics. And maybe this is the big reason of calorics is still, popular, because, other vestibular tests like the rotary chair, and you cannot test each side individually. So the vHIT, you can assess semicircular canals, while the calorics you assess only the lateral semicircular canals. vHIT is very quick to perform. I mean, for something who has experience, you can do the test in 5 minutes. I can tell you that sometimes I spend 4 minutes testing all different canals in a patient. So it's a very quick test. And calorics takes lasting at least 20 minutes. I mean, it's very unusual for someone to do a caloric test in less than 20 minutes. So vHIT is a very well tolerated by the patient, even patient in acute phase, which means sometimes you are, in acute phase, you have nystagmus and you have vertigo, but you can still do in the vHIT. And I dare someone to do the calorics in the acute phase. I mean, it's very unpleasant for the patient. vHIT, you access the labyrinth in a high frequencies, which is much more physiological way to access the vestibular function. In the caloric test, you test in a very, very, very low frequency, which is a not physiological one. And one of the advantages is also because vHIT is a very, it's highly repeatable, which means you can do that in a very repeatable way. And calorics is extremely variable. I mean, you can compare the right side and the left side of the same patient, but you have to be sure that the stimuli was the same, that the ear canal has the same, form, the patient has no tympanic membrane perforations, they have no middle ear disease. I mean, there's a lot of variability in calorics. And what is most interesting about vHIT is because you can test, retest how many times you want. I mean, sometimes you are just in following up with the patient, following up a patient, a neuritis patient, and you can do vHIT every, time you see the patient, you can do the test. It's a very well tolerated, but hardly the patient will tolerate more than one caloric test. I remember I had a patient, a couple years ago, and he told me that he went to an ENT doc, and the ENT wants to do caloric every time he goes to the office, and he's, he just stopped to go to the ENT because he cannot tolerate calorics. So, I'd like to, bring your attention for some data about the DC patients. And in this paper here from Baltimore and Sydney group, they show us that just in the United States, they have 4 million U.S. emergency department visitors for acute vertigo or dizziness per year, which is huge. 4 million visitors for dizziness, and just in terms of comparison, you can remember that Denmark population is a little bit more than 5.5 million people. So it's like Denmark goes to the United States emergency department just complaining about vertigo or dizziness per year. And what is more terrifying is that over 1 million of these 4 million here are overtested, misdiagnosed, and undertreated. And why does that happen? I mean, when you have, vertigo attack and you go for emergency department, I guess everybody does a CT scan or MRI, and you perform a lot of blood testings and cardiovascular tests and neuro tests, and sometimes the emergency department doc, he is not familiar with the vestibular disease, so they got misdiagnosed, and of course they are under treatment. So it's extremely important for everybody to know and to learn how to deal with this patient here. And what's the cost of that? In the United States, they spend $9 billion a year with this patient. $9 billion. I mean, it's so much money. I have no idea how much money is $90 billion a year. So I took plot here of the GDP of the world, and you can see all these light orange countries here in Central America, in South America, in Africa, and Southeast Asia. They don't produce $9 billion in their economies per year. And you can, have an idea how much money is spent in the United States. So for us to finish this presentation here, I'd like to, to show you some examples of how vHIT can have clinical applications here. So let's pay attention to this clinical case here. This is a 46-year-old male. He's a mechanical engineer, and he had an onset of acute vertigo just 4 hours ago, and he has no other health issues. He's a young guy, pretty healthy, no hearing loss, and no chronic medications. And he went to the emergency department. He was nauseated and vomiting, and his blood pressure was quite high, just because he was nervous. And when we deal with the patients in acute phase, I do recommend it for everybody to read this paper here. It's a paper from Dr. Katai and Newman Tucker from Baltimore, and this paper, it has been published, I guess, in the Stroke Journal in 2009, and it gives information about what we call HINTs. What is the HINTs? HINTs is the head impulse, nystagmus gauge, and test of skill. And when you approach acute phase patient with this, 3 tests here, maybe you got more precisely than an MRI in the first 24 hours. And let's apply the hints in this patient here. So look at the head impulse of this patient. You move to the right side and you see a saccades, okay? And left side seems quite normal, right? So if you do in slow motion, you can see to the right, look, the saccades. So I know that the right side is broken. So when we pay attention to nystagmus gauge here of this patient, I hope everybody's seeing the video, perfectly, but this patient has a left beating horizontal nystagmus. And when he looks to the left side, it increases, and when he looks to the right side, it decreases. This is the Alexander law, and it tells me that this is probably a peripheral problem. And the test of skill, there are no skill deviation. So you do a cover test, and you see no, vertical strabismus, which is, probably a peripheral disease. So let's pay attention here. The patient is with eyes open. With the video, you see a left beating nystagmus here with the eyes open. And what we can do here, you can see the nystagmus beating to the left side. When you, close the eyes, the nystagmus, become more intense. It's still horizontal, it's still left beating, and you open the eyes again and ask the patient to look to the right, to the left, and the nystagmus increase. When he looks to the right side, the nystagmus decrease. So it probably gives us the information that the right side is not working properly, right? So when we do the video hand impulse here in this patient, so there are a lot of interesting information here. First of all, the VOR gain is low in the right lateral canal, and the gain is low in the right anterior canal. But in the posterior canal, the gain seems pretty normal. So I have this movement here, which is the spontaneous nystagmus that have been shown in the healthy side. And they do have the saccades, over saccades and cover saccades. So I can tell you that this patient here, he has probably vestibular neuritis. And the vestibular neuritis, it's affecting just the superior part of the vestibular nerve because it damages the lateral and the anterior canal. And it spares the posterior canal, which means it spares the inferior parts of the vestibular nerve. So this is the 3D, which is a nice view. I remember Dr. Halmagyi, he used to say that we should look for the tunnel here. And you see the tunnel in a very clear way in the lateral and anterior right side canals. Here is the next plot. which is a nice way to, display the results. You have the anterior canals, the lateral and the posterior. You see the right anterior is broken, the lateral posterior, and the lateral right side lateral is broken as well. So what is the conclusion of this case? It's a very typical case of acute unilateral vestibular hypofunction, probably neuritis, and it takes just the superior branch of the vestibular nerve, and it spares the inferior part. So to make sure that we're going to remember hints, there's a mnemonic here, an easy way to remember the hints to infarct. Infarct is a patient with central vestibular pathology, and they use it to have normal impulse, fast phase alternate, and refixation in cover tests. And this patient went to MRI, and MRI was normal. I can ask you, does it really necessary with the HIT protocol to ask for MRI in this case? I don't know. This is a discussion that we can, have another time. So I want to show you what's happened with these same patients 18 days after the onset. So 18 days after that, he came to my office, and you see there are no spontaneous nystagmus anymore with the eyes open, right? And when you do the eyes closed, you see no nystagmus anymore, which seems pretty nice compensates. And I went to do some head shaking in attempt to, testing the asymmetry. And the head shaking, it's quite normal. There are no nystagmus after the head shaking. And I did a vibration nystagmus as well, trying to, see if the patient has any, asymmetry. And there are no nystagmus vibrations at all. So this patient seems pretty normal, right? And I did the vHIT again. And what we see in the vHIT, the gain is recovering, right, in the lateral canal and the anterior canal. You see no spontaneous nystagmus here anymore. And, the saccades, the over saccades, they become much more, cover, and, you have a clear way of being that. And this is a nice plot. And the software gives us how the gain, increases from the first visit to the second visit. And you can, show to the patient how much he's recovering. And look what happens with the over and cover saccades. This is in the first evaluation here. This is in the second evaluation here. So the patient's pretty much well compensates. The gains, recovery, and the spontaneous nystagmus disappear, and the saccades become much more, clean, but they still having some cover saccades here. So this is the information I have today. I'd like to do some acknowledges. All these guys here, some of them are my close friends, some of them are great research, and I do recommend that everybody to read these publications here. Dr. Barin, he has some nice, presentation with the Otometrics channel, and this is a very, multidisciplinary team. We have audiologists, we have PhDs, we have, otolaryngologists, you have neurologists, and you have physical therapists. And, all these guys here, they have some kind of, they teach me something about vHIT hypostasis. So thank you very much for the audience. I hope everybody like it. And I'm completely available for any kind of questions that you have.
Thank you, Renato. It was a really nice presentation, and you got some questions. We are a little bit late, but I think we should take just a couple of them. The other ones I will answer to you in a mail to the people that have sent to us. Another comment is someone said that it was really difficult to see the videos, and I agree with that. I will talk to Renato afterwards and see if we can make it available somehow. So just one question, Renato, for you. What can I expect of the vHIT how would the vHIT look like, the results in a Meniere disease patient?
This is a very tricky question here, because Meniere disease is, for definition, it's a very variable disease, which means it depends. Sometimes if you evaluate the patient acute phase of a vertigo attack, you can have one result of the vHIT. You can have a normal vHIT, or if you evaluate this patient in in other time, and this patient evaluate at an evolution with hypofunction of the Meniere side, you can have another result. So I don't think that there is a pattern. There's not a pattern for Meniere's disease. I mean, I guess it depends in what is the time that you evaluate the patient.
Good. One more, Renato. How would you understand hyperflexia in the vHIT?
You mean in the calorics? When you do calorics and you don't see responses, you see a hyperfunction, right?
I think is that what the person is asking? Yes.
Okay. So if the patient has a hyperfunctioning caloric test, it shows us that probably the labyrinth is not working properly. And what we can expect in vHIT is a low gain in that side. And you can see a low gain, and probably you're going to see some saccades. I mean, cover and over saccades. And one of the information that comes to the vHIT software, and I think that's very informative, is the asymmetry ratio between sides. So if the patient has one side hyperfunction, you're going to see a huge asymmetry.
Okay, thank you. Are cover and over saccades both indicators of peripheral vestibular hypofunction? Are there other causes of cover saccades?
This is a nice question. The origin of the cover and over saccades, they seems not to be the same origin, which is it's interesting because there are some research doing head impulse in darkness, and in darkness the people don't have over saccades, but they still having cover saccades. So my guess is that the cover saccades and over saccades, they're not coming from the same same place. So maybe it's not just in peripheral disease. You do have some very interesting central findings in the vHIT, and with this the central pathology, these patients, we have to pay attention, because sometimes, for example, if you have a saccades but you don't have a low gain, something's wrong. I mean, something's wrong, and maybe it's an artifact, or maybe it's central, or sometimes if you have a low gain but you have no saccades at all, so something is wrong. And I use it to, I'm not going to tell you that over and cover saccades is peripheral disease, but I do recommend it that when you perform a vHIT and you get some weird results that doesn't make sense, looking for a central cause.
Well, we are going to take the last question now because we are a little bit late, and don't be afraid, we will answer your questions by email. So there's another question for you, Renato. Great speech. Do you believe that vHIT could become a reality in emergency rooms, mainly for patients with symptoms of stroke?
I'm going to tell you something. I'm an enthusiast with vHIT. So I do believe that vHIT is going to become the most widely, tool to evaluate vestibular system. I'm not sure if we're going to use that in the emergency departments. I hope so. And, the vHIT, when we compare it with calorics, it's, they have a lot of advantages. They have a relatively low cost. And I do believe that, vHIT, I hope so, vHIT becomes available in all emergency departments. I think it's a great tool for, so I know that some research use it to tell that the vHIT is going to become the EKG of the emergency departments. I'm not sure if it's going to become the EKG, but I do hope that it becomes popular.
Renato, I would like really to say thank you for this good presentation. You got a lot of acknowledgement for your presentation in the questions. I'm sorry you can't see that, but I will share with you afterwards. Thank you very much for all the participants to be here with us today. We are going to be here in about a month from now again with a new topic.